this is I'm still really looking forward to this talk, and it's my pleasure to introduce Dr. Waseem for a talk today. Dr. Waseem is finishing up her addiction psychiatry residency program here at U of L. And can you hear me? All right. Let me check. Can you guys hear me? All right. I got a message from Dr. Caudell in the middle of that, so I was not sure. Look, this has been a great year for the addiction program. Dr. Waseem has really brought a lot to our program. I just want to again express my gratitude to Dr. Waseem, and again, she's going on to work in the child psychiatry department after this month. We're really proud of her. And this talk is really important topic on stigma that she's giving. She's really had a lot of initiative this year. She's had a couple of publications and already, which is really pretty unusual for a fellow in 1 year, and in areas of opioid use disorder. And so anyway, really a great year. And again, it's going to be all right. It's all going to be okay. We were trying this hybrid presentation, but again, thank you. You might not know, Dr. Waseem is a social media influencer. She has over 35,000 followers, I think, on Instagram and YouTube with areas related to mental health. And she's very, in her presentation, she's quite reflective. I think we're going to see that in the presentation today. And again, we appreciate everybody's patience bearing with us. And thank you, Dr. Waseem. Good luck. And I'm sure we're going to be able to get something out of this already. Thanks.
Thank you, Dr. Stewart. I apologize for this technical glitch over here. I'm sorry I can't get the slides to display. I just wanted to publicly also thank Dr. Stewart. He's been a life changer for me. He's helped me regain my trust back in the field of psychiatry. So I just wanted to say that publicly. So thank you, Dr. Stewart. Thank you all for being here in person. I know it takes a lot, and it's a bummer that you can't see the slides. So I apologize for that. And thank you everyone for joining virtually. So as you all know, the topic is unmasking addiction stigma. The speech bubbles, if you can see the slide, if you can, are basically quotes from people that I interviewed. You'll get to see their testimonial videos. Hopefully you can hear what they're saying. So the speech bubbles will make sense. I can just read them out to you right now. They say, I don't want to feel the shame you imposed on me. They imposed on me. It would have been beneficial not to tell. Bad kid, follower, attention seeking. You could choke me or leave me in a ditch. So these are just quotes from those people. Makes sense shortly. All right, I wanted to just begin by reflecting on some questions that fellow residents and attendants asked me when I started my addiction psych fellowship. Why an addiction psych fellowship? What are you learning in this fellowship that you didn't learn in residency? Are you going to work with addiction-focused population? Are you just riding your visa situation through this fellowship? So I'm not sure if I'm going to answer these questions, but I did want to. Don't know what happened. No idea. I'm sorry, I'll get back to it. I have no idea what happened here.
Share your screen.
It just dropped.
Recording in progress.
So I'll just didn't want to answer the question, but wanted to look at maybe the sentiment or maybe possible bias or maybe some assumption that these questions were coming from. So why an addiction psych fellowship? To me, that sounds like, hey, why are you wasting your year doing this? And then what are you learning in this fellowship that you didn't learn in residency? To me, that's an assumption thinking, hey, I got out of residency feeling fully competent and ready to treat my patients with substance use disorders with empathy and competency. Again, a little bit of an assumption over there. Are you going to work with addiction-focused population after this? To me, this is like, hey, like maybe adult psychiatrists or child psychiatrists don't have to work with substance use disorder population. So are you just riding your visa situation through this fellowship? For international medical graduates like myself, maybe don't care about learning. All they care about is just visa and immigration stuff. So this slide I want to just share with you all to, reflect on what is the prevalence of substance use disorders that you all psychiatrists and mental health providers will get to see with your population. The numbers are taken from epidemiological catchment study, ECA. So if you just broadly look like for any psychiatric disorder, the prevalence of substance use disorder is close to 28.9%, almost 30%. And if we go down, go to bipolar disorder, it's 56, pretty significant. Schizophrenia, 47. So thinking that we don't have to deal with substance use disorders is probably just closing our eyes to a reality. This slide I want to share just to bring our sort of attention to how big a problem substance use disorders is these days in United States. So the mortality related to drug overdose in the United States since 1999, 1 million people died in since 1999 from any drug overdose. It's a crisis. Now, the bigger reason for this crisis is the fentanyl contamination of most substances. So even if your patient is maybe not using opiates, they're still at very high risk of dying from overdose without realizing that there was fentanyl in what they're using. So just wanted to bring your attention to that. Wanted to just share this slide. If you can see again, it is the map. It is taken from the CDC website just to show that Kentucky is pretty high up in terms of overdose mortality rate. It is close to West Virginia, Tennessee, and Louisiana compared to the rest of the United States. Pretty high up. So if you're a psychiatrist working in Kentucky, the burden of dealing with patients with substance disorder is pretty high. But what are the barriers? Now we realize, yes, when you're dealing with it, there are a lot of barriers in our being able to truly help this population. I wish you could see this picture. I wish people here could see this. I posted a picture of myself from 2018 when I was working in EPS. I'm smiling wide. I look very confident, as if I knew what I was doing. At that time, I thought I did know what I was doing. But turns out that wasn't the case. When I started my addiction psych fellowship, it took me that long to become aware of what biases I had for this population when I was working in EPS. Yes, it took me that long. So what were those biases? I want to be very transparent, honest, and vulnerable today with you. I'm not trying to shame anybody. That's why I'm just using myself as an example. But at the same time, no, I'm not the only person who had these thoughts or biases working in EPS or in residency. Whenever I would see a patient come with a positive urine drug screen, my thoughts would be, oh, let's print out a list of CD treatment facilities, hit the discharge button. This is the quick patient, how easy. Or this is not the right setting for addiction treatment. Addiction treatment is not my role. This patient is such a burden on resources. People with real mental illness deserve these resources. I'm just following what attending the residents are doing, so I'm okay, whatever I'm doing. This patient is suicidal because of substance use. Or if only they could quit using substances, they would make everyone's life easy. And then some helplessness. I don't know how to help this patient. I feel bad for this patient, some empathy as well at the same time, and then quickly dismissing that empathy, saying, but this patient is sabotaging their own treatment. Just, again, a little bit of defensiveness, protecting myself. And then, oh, they may have children at home. Do I need to file a CPS report? Thinking liability again. So all these biases, I hope you can sort of recognize a little bit, is what I was carrying when I was working EPS. Real quick, what is stigma? Coming back to the topic, stigma in the simplest of definitions is a mark of disgrace, and bias is a prejudice in favor or against something. Stigma and bias, overall stigma refers to the whole broader system of that bias, which exists in the social system, and bias is more individual, and they both feed into each other like bidirectionally. So if there is the stigma in the system, then you're going to internalize it. That shows up in your interaction with the patient. And then that interaction causes self-stigma. We'll talk about that. That feeds back into the system. So they both feed into each other. So they go hand in hand. Origins of the word stigma, real quick. I'm not a historian, but I was curious. The stigma word basically exists from ancient Greece, where it referred to the actual burn mark or tattoos that they place on criminals to outcast them or to slaves. And that's what we're doing to this population. The stigma is still there. Stigma in literature broadly is divided into 3 different types, like public stigma, structural stigma, and then self-stigma. Structural stigma refers to the system, like social justice system, the criminalization of drugs, the the child custody issues, employment opportunities. That's the stigma that exists. Public stigma is what we healthcare providers are part of that. Family members of people with substance use are part of that, patients themselves, and then the self-stigma is as a result of this stigma around, they take it in. And it's important to note, research has proven again and again that the self-stigma exists only because of the social and public stigma. They're not born with that. It's based on the rejection they receive. It's based on the interactions they receive. I wish you could see this picture as well. This is a picture that, before talking about the picture, I want to say, so it was not until the first week of my addiction psych fellowship that I fully became aware of what biases I was carrying. I'm not saying I was able to overcome that. I became aware of them. Why? Because if you can see this picture, this is taken from the Suboxone street induction site at Portland Clinic, where it's initiated by Dr. Stewart, that we actually try to go meet patients who are in active addiction around the Portland area, the homeless population, and offer Suboxone, educate them about what it is, get to understand how much they're using, what it is, teach them about the risk of precipitated withdrawals, give them like 3 to 4 days supply of Suboxone, give them comfort medications, give them an appointment to come back to HCOC. So this made me realize this is the opposite side setting to what I was doing throughout my residency for 5 years. Totally opposite. I'm saying, I'm coming to you as a healthcare provider. I'm here to help you. I want you to get sober. I want you to stay alive, basically. And I'm like, oh my gosh, I was just discharging them from EPS all the time. Or if I was on consult service, I'll come to that. I was hesitant to give them more Suboxone. I was hesitant to titrate the Suboxone. So it was this is when my mind totally changed. I'm like, oh my gosh, what are we doing? And how successful this program is beyond the scope of the presentation. But I do want to say it is definitely successful, especially in reducing stigma within me. And I'm sure it's helping those population out there as well, who would often be surprised and be like, is that a doctor offering Suboxone here? Literally, that's what patients were saying over there. So that's the level of stigma that we have, that they think that doctors are not here to help us. They're just going to discharge us from the hospital. So overall, the stigma relies on this moralistic bias for substance use treatment, which is that these people are just morally weak, or they're not able to just exert their willpower to get sober. That's the overall bias that I think that we're operating on, which stems from lack of understanding of how complex addiction is. So addiction is now the broadly very well accepted model of addiction is the brain disease model. However, there is some obviously critique that is oversimplification and taking away the responsibility. But there's been evidence to prove that there are significant brain changes in people who use substances for a long, long time. You can go look at brain scans of people who use meth for so many years, opioids for many years. So that biology component is definitely there. So it's helpful, just view it that it's a complex disease. It's chronic. Relapse is not a moral failure. Relapse is a symptom of the disease. There are brain changes. There are social system is designed against these people, so it's hard for them to get out of this loop. And then there is genetic predisposition. There is psychiatric underlying trauma, psychiatric problems, and then of course the behavior patterns come in as well, which is where the role of CBT, DBT, contingency management, all those therapies comes in. But just understanding as healthcare providers how complex this is might be one way to help us move away from the stigma. What does provider stigma do? Provider-based stigma can show up in many different forms. Let's look at the right side. It can show up in a negative attitude. That's the simplest, the most crude form. It can show up in like some language that we may not even use with the patient, but it shows up in the notes. It shows up in our interactions. And I'll come to that as well. This patient is pain med seeking, frequent flyer, all of these things. We'll use that in EPS. We'll use that in consult service all the time. But the biggest problem with the stigma is that it shows up in treatment bias, which is so many providers are hesitant to start MOUD, which is medications for opioid use disorder, or medications for other substances as well. They want to promote the abstinence model, that no, just gotta have the willpower and quit using and get sober, which is dangerous. People can die. because they get sober, tolerance drops, they go out, they use one time and they die. And that's what's happening in the opioid crisis. So the biggest problem with this provider-based stigma is the treatment bias that we have. And we're hesitating to initiate or continue the medications for opioid use disorder. This is just, I wanted to share with you the systematic review that's been done to show that majority of healthcare providers carried a very negative attitude towards this population. And they perceive the patients to have violence, they perceive the patients to have low education. As a result, they didn't provide quality healthcare service to the patients, and patients felt disempowered. So provider-based stigma, as I've already mentioned, contributes to underutilization of the medications that are out there that are evidence-based model. And it says that only 1/3 of patients with opioid use disorder actually seek medications for opioid use disorder. And research has also fully established that treatment healthcare provider stigma leads to the self-stigma that these patients have, which is they think that, oh, I don't want to start another medicine because that's like another addiction. I give up heroin, I give up fentanyl to take up Suboxone, and methadone. So that's coming from the doctors as well. So we have to just be mindful of that. This is just to show you how shame is such a huge part of this problem as well. And we are becoming a part of that system by having these biases and stigma. So there's a moralistic bias, then we have limited resources, we're not trained enough, then we carry the treatment bias, then we do stigmatizing language, the patients develop the self-stigma, and the shame just is all around this. Again, just to show you on the right side is all the problem of the cycle is by the healthcare providers. Moralistic bias, treatment bias, stigmatizing language, trauma, medical trauma, I didn't talk about that. So this can be super re-traumatizing for the patient, these interactions. I'm trying to just rush through the slides in the interest of time. This video, so I did go on and I talked to different people. I have some videos of testimonials from people in active recovery and some healthcare providers. This one is to begin with a healthcare provider. I hope you can hear this video. I asked him the questions about how much training did you receive in treating substance use disorders? Have you observed any biases that you may hold against individuals dealing with substance use issues? It's Dr. Hassan Chaudhry. He's an internal medicine doctor. It is about 4 minutes long. I'll see if I need to stop before he finishes.
My name is Hassan Chaudhry. I'm an internal medicine physician practicing in Phoenix, Arizona, primarily inpatient hospitalist setting. I've been asked to speak on implicit biases associated with this.
Can you hear it all? No.
And I only remember my name is Hassan Chaudhry.
This is the maximum.
I only remember.
No. Okay, so I'm going to just stop. I'm sorry. So basically, this provider, I can just summarize what he shared. If you don't mind muting. So the provider basically talked about that, how he did not receive enough training in treating substance use disorders. And whenever he dealt with patients with history of IV drug use, they would always refuse blood draws, and that would get him very frustrated. He would get mad. Again, not understanding that people who with IV drug use will be hard stick. Their veins are hard to find. So he just had that bias. And then his perception eventually changed when he started rotating on behavioral health unit and realized that these patients had a lot of untreated anxiety. And he developed some empathy from that standpoint and started looking at them differently. He did, towards the end of the video, express some explicit bias and not implicit towards people with alcohol use disorder. He said they are more violent and they try to hurt other people. So I just wanted to make you aware of there are certain explicit biases as well, and we'll talk about that. And then they came up the concept of intersectional biases as well, because he also mentioned how he had some biases more towards the Black population that he was dealing with. So that is where sometimes intersectional biases can cause compounding effect as well. So that's just something to keep in mind. And then at the end, he mentioned something about the big question, should drugs be legalized? Because alcohol is, marijuana is being legalized. Should opioids be legalized as well? The big questions. Just wanted to share real quick what implicit explicit biases are. As the name, we understand it just by looking at it. Explicit is you were aware of it and you hold on to it very strongly and it shows up in your interactions. Implicit is something internal that hopefully we can gradually become more aware of and then see what we can do from it. There is actually implicit bias training, which is mandatory in many states for healthcare providers. I have a whole list of states here where it is mandatory, and all healthcare providers have to get that training, whereas Kentucky is not on that list, unfortunately. It would be helpful if it was. So I guess we've established that we all have to we all have to work with substance use disorder population, and we all have, no, we all don't have to use drugs, sorry. And we all have implicit biases. Well, at least we laughed. So those who know me through residency know that I'm not big on research at all. I'm not a nerd like that at all. Unfortunately, I wish I was. So I didn't write much. I didn't publish much at all. I don't know how I feel about that. But when I started my fellowship, there were certain incidents that made me feel very strongly, and they compelled me to write about it. And that's what I want to share. I did end up publishing this in a local journal, and I was so proud of it because finally I published. But the story is what I want to share with you. What happened was, so on the sud service, I was
here.
Someone else's, I think, mic. I don't know. Okay, anyways. So I was consulted on this patient that was found down. She was a middle-aged lady, was positive in her urine for multiple drugs. I go up to her, try to talk to her in the ICU, try to establish rapport. She's very distressed. It takes me about 40 minutes to sit next to the bed. She's opening up to me, and suddenly this gentleman who I understand attending just walks in, and he just ignores my presence and literally blocks me like this towards the bed, and I'm sitting behind, and he starts talking to the patient and says, someone's mic needs to be muted from the audience. Okay. I hope the computer. So, and then he starts saying introducing himself, and there's a whole team of 10 people over there, and I'm sitting, and we were in the middle of maybe talking about patient's trauma over there, like she was crying, she's talking, and then, okay, I'll ignore the humming. So then, but the patient is puzzled, and she looks at the doctor and says, what happened to me? Because she didn't remember. And he responded, looking at the patient, saying, you were found down, wrapped in a blanket on the roadside, your clothes were torn, and the police brought you in. He says this, and I was shocked the way he delivered that with insensitivity, without any giving comfort to the patient, reading the room, recognizing she may be distressed. And she looks at me, starts to look at me sitting behind the doctor, and says, please don't leave. So I don't know what you guys think of that interaction. To me, she felt like her privacy, her safety was violated. She was talking to me. And then somebody comes in and just says this without any sensitivity. You were wrapped in a blanket, you were found down, your clothes were torn, and the police brought you in. I thought that just blew me off. I was like, what was this? And so what was this? This was stigmatizing inaction. Yes, bad bedside manners, but what is it coming from? So he probably had a moralistic bias. Okay, she had drugs in her system, whatever. She doesn't care about herself. She doesn't care about her safety. She deserves this. All right, so this is what happened to you, ma'am. Like, how insensitive. And where is it coming from? Yes, poor bedside manners, but there is the bias over there, which is operating behind all of this. Did he understand that she could have trauma? Did he understand what trauma-informed care is? Probably not. And not to miss, this is just an aside on the intersectionality of biases. Maybe he had some physician elitism bias. He didn't think I was a physician there. He maybe had some color bias from a brown skin. Maybe he had some gender bias, a woman. Maybe I'm just a sitter in the room. So that's just an aside, but to share with you how intersectionality of biases can compound everything. So talking about trauma-informed care is, I think, SAMHSA's guidelines are that all healthcare organizations should be trauma-informed. What it means, I didn't want to list down all the things, but number 5 was most important, which is the organization to seek to resist re-traumatization. And that's what this doctor did. He re-traumatized this patient. That every time I open up or I deal with somebody, either that gets interrupted and somebody else comes in and just throws it at me. What a mess my life is. So maybe we need to think about not re-traumatizing our patients. Trauma is a huge part of this population, of the whole issue of substance use disorder. The causal relationship between PTSD and substance use has been well established, and also been established that when they use drugs, they also makes the symptoms of PTSD worse. We know this already, and in-depth studies have been done that people with more arousal symptoms tend to use more alcohol and opiates. People with more avoidance symptoms will try to use more stimulants or cocaine. Just wanted to share these stats with you that it's been well established. So maybe having a trauma-informed lens when we deal with these patients is probably something we should all think about. So here's the first testimonial of Rhonda, who's right now 20 years in recovery. She talks about her experience. I really wish you could hear this. I don't know.
They can hear it on the Zoom.
So maybe one person, but then it'll be an echo.
I don't know if that's possible for us, but the
You can give it a try and see. I couldn't hear the video, when I was out in the hall. I couldn't hear Dr. Chaudhry talking. I could barely.
A recovering addict. I definitely felt a lot of
She's
stigma
louder.
from medical providers
Can you hear this?
over the years. And unfortunately, medical charts contain that I have substance use disorder, but most of them don't show that I'm in remission. I've been clean almost 20 years, but still get stigmatized about that. So the most prominent experience of my life was 5 years ago. I had a heart attack, and I was stressed. I knew like what I was going through, but I was also in denial. And the cardiologist came in and said, "Hi, I'm Dr. So-and-so. I'm going to be your cardiologist. What's wrong with you? Are you on drugs?" It really, like, I asked him to leave my room. He offended me. I had been sober 20 years almost at the time. And I didn't even want to deal with him anymore. And then unfortunately, I had to agree to allow him back in my room because I had to do an emergency heart cath. I feel like that has prevented me probably from following up like I should about my heart. It definitely causes all kinds of problems when I do have some heart symptoms. I don't want to go to the ER. I don't want to deal with the symptoms because I don't want to feel that again. I don't want to feel that shame he imposed on me when all he would have had to do was look at my chart a little bit deeper, and he was seeing that I had almost 20 years of sobriety. And he didn't. And I experienced that a lot.
I hope you were able to hear that she went in. Okay,
Yeah,
perfect,
that's good.
perfect. So here, this was wow. So substance use almost took precedence over a heart attack. And the result of that, she didn't want to go in to get treatment for heart attack later when she has the chest pains. What's wrong with you? Are you on drugs? Well, alrighty. So then I have another testimonial from Antisha. This is shorter. Let's just hear. Antisha has been in recovery for 3 years.
Oh, yeah. So my name is Antisha. I've been sober for a little over 3 years now. And so my experience with stigmatism in the healthcare system was, I felt like I think I started having problems with substances when I was 22, 23. And so I had my first son, and I was sober through that. And then I think somewhere through there, I either visited the hospital 1 or 2 times or such, and it had been documented that I was drug researched or not. So anytime I go to the doctor, it's not really about the care or service they could provide versus the care or service they could provide to a drug user. So I was in a very loose relationship, and I would run to the doctor, right? And I remember going to the doctor one time, and my ex at the time had beaten me, and I think we'd used drugs earlier in that night, right? I'm also dark-skinned. So funny thing about it is I bruise differently. And so I remember running away like I finally got away from this man, and I ran to this immediate care, and like I'm telling him this story. So I didn't know that they didn't believe me. First, they put me over in this little side room, and then immediately they called Our Lady of Peace. And Our Lady of Peace comes to pick me up, right? Because I'm crazy. I'm crazy, I'm a drug user to them. Not that I just reported that someone had tried to kill me. And so that relationship lasted for about 4 years, and I would go. There were a couple more incidents where I would end up going to the doctor, and the very first thing that they had asked me, have you used drugs in the first 24 hours or last 24 hours? And like it just seemed like that was a stipulation of how the care that I received, right? Because if I use drugs, then it doesn't matter who's beating my ass. Things that helped me get sober, though, because I realized that it didn't matter what was being done to me. If I didn't get sober, you could choke me and leave me in a ditch. And as long as I was a drug user, how you would remember that, or how we said, was that she had she had problems with drug use and blah, blah, blah. Not that anyone murdered me, right? Not that that was the reason. It would have been nice to have seemed relevant, right? Like people had cared about what I was going through.
Wow. So we heard some domestic violence, and it wasn't taken seriously. She had a history of substance use disorders. She also talked about intersectional bias, that she's black skinned, she bruises differently, had a hard time, healthcare providers would not believe her. And we do know, I don't remember the number, but every time somebody gets choked in domestic violence, it's a very high rate of them high chances of them dying in that. So again, just recognizing that these things are high risk, but because of that history, the biases are coming into play. I mean, treatment plan, what they would have done may not have been different, but it's how they made her feel when she showed up every time. Nobody cared. It didn't matter what was being done to me. So Rhonda actually also talks about her experience of reporting domestic violence in the ER.
I've been a survivor of domestic violence. That secondary trauma you experience as when you go through domestic violence is horrific. You know, police want to take pictures of you, and and then when they see substance use in your chart, they're automatically, oh well, that's probably why it happened, or and that's not true. It's just such a stigma. I wish medical professionals would understand more.
That's probably why it happened. I mean, that's hurtful. So again, just wanted to bring that in, that there were 2 women that I interviewed, and both of them had reported the same experience. Coming back to my story. So I'm rotating on subservice. Of course, fortunately, I didn't have to work any weekends this year, which was great. I come back Monday morning, and I see in the chart that my own fellow residents would have done some weird things with the patient, like the patient is med seeking. This is in the note, pain med seeking, not titrating Suboxone. Or they start a patient at a much lower than home dose of Suboxone. Why? I don't get it. Or the patient gets discharged without getting a Suboxone script. Sure, there are always, sometimes that happens, but how often do we send a patient with sepsis or cellulitis without an antibiotic home? But it happens with our population. And it hurt me more because it's our own residents. I've done this too. Patient is pain med seeking. So again, the bias is still there within us as psychiatrists also. Language plays a huge role in feeding into the stigma. Again, research has been done on this, and there are fortunately some changes that have been made. So just the language, drug abuse and drug abuser, we've gotten rid of that because studies had shown that the language we use impacted the attitude we had with the patients. So it does run deep. So there was this study done, which is pretty impactful by Kelly. So as a result of this study, there were big changes made on policy levels. So like the director of White House of National Drug Control, they went in during the Obama administration, they initiated the changes that trickled down to changes amongst the journalists. And then eventually we saw the language change in DSM between 4 and 5. Abuse and dependence has been replaced with substance use disorder. So words do matter. We need to be focusing on person-first language or person-centered language. We're already aware of that, but just a good reminder. Like we want to move away from the word addict, this person with substance use disorder, drug, or substance of choice. You won't believe it. I wrote this in my own note at the VA, and a psychologist said, shouldn't write substance of choice, drug of choice, because it's no longer a choice. Their brain has changed. It's primary substance of use. So I learned this only a month ago. So I'll just share that with you all. Medication-assisted treatment, gone away, replaced with MOUD. Alcoholic, person with alcohol use disorder, former addict with person in recovery. Dirty urine, no. Positive drug screen, clean, negative drug screen. Substance abuse, substance use disorder. Frequent flyer, no. Frequently visits the hospital or frequently visits the ER. John is actually also in recovery, and he's a director of nursing in 7 counties. So he spoke twice, one on behalf of his experience as a person in recovery, and then he speaks as a person, as a healthcare provider. And so this one is, he speaks as his experience as a person in recovery.
But I was, I think, 5 years clean and sober at that point. And I disclosed it, like I said, to help me, not necessarily be used against me. I never would have thought that would have came back into work against me by disclosing that. Stigmatism that I have experienced towards me personally being in recovery, and I was already a nurse, had many years in recovery myself, and I had a situation on relating to healthcare where I'm always very honest on my disclosures and disclose my history because I feel like that's an asset to help me. So I don't hold back or not tell, but this is a situation where I felt like it would have almost been beneficial to me not to tell. So I had actually had a real bad tooth infection, and I had to get a root canal. And before they could do that procedure, I started on antibiotics, and I went to the dentist and got medication, but she would only give me 2 days, even though the next step in the procedure wasn't going to be for several more days after that. So I was in a lot of pain and a lot of discomfort to the point where almost not allowing me to even be able to work. I was in so much pain and discomfort, and they did prescribe me some pain medication, which helped quite a bit. The problem, like I had mentioned before, she only gave me a 2-day supply. And even taking it as prescribed and maybe even longer, I made it stretch for as long as I could. And when it ran out, the pain was still there. The infection hadn't been completely cleared yet because the antibiotics were still taking its course. And I tried to follow up with the dentist to see if I can get more. And because of my history, I was literally told this at the front end, but apparently they had reached out to the doctor, and because of my history, she would not prescribe me more. So I was forced to, in that case, literally endure pain because I wasn't able to get anything to help me with the pain.
I'll just stop this one there. So the big question is, so he had been 5 years into sobriety, he's functional, he's working, director of nursing. What would you have done? I just want you to reflect on that. You don't have to share the answer if you were the dentist. So I'm just curious. He says later in the video, he wasn't able to go to work because that's how severe the pain was. And so he had no reason to tell the dentist that he has history of substance disorder. He offered that in the spirit of honesty, and it was used against him. Sarah, also in recovery for 18 months.
My name's Sarah. I'm in recovery. I'm currently 18 months sober. I began using substances at the age of 12 years old, nearly 16, 17 years ago. I was using pills, alcohol, cocaine, anything really I could get my hands on. I lost my best friend at 16 to an overdose, which led me to realize that I needed to change my ways on substance use. I began getting in legal trouble. It was to the point where I was threatened with going to drug treatment or going to jail, and drug treatment and counseling and therapy, court ordered. I had spoke with my therapist and opened up with all of my substance use. I was probably about 16 or 17 at the time. And all it led to was her disclosing to my father the information, and so that I got in trouble. I was always labeled the bad kid or the follower, and nobody would ever take the time to wonder why the 12 to 16-year-old wasn't using substances. I was attention seeking, and nobody would just ask why. And after being betrayed by that therapist, I felt that I couldn't open up about my substance anymore.
So this one is a little bit controversial, that she was, I think, under age of 16, and her provider gave it away to her parents. So I looked it up. Actually, it's whether it's legal and helpful to inform or not. So in terms of legal, it's not binding in Kentucky to tell the parent if the minor comes and discloses substance use, but it said may inform the parent. But I guess I would encourage you to think about, is that whatever suggestion, is that designed to protect the provider, or is it designed to really help the patient? And also, it would be helpful to think about, what did the provider do? Did the provider carry some bias? Did she act out of anxiety? Oh my gosh, I need to tell the parent and get this responsibility off my table. And then, did she really understand what she could have done to help? She could have maybe had a family meeting. She could have offered like more long-term care to be on board. So just I think this is coming from a place where she didn't fully feel equipped to handle this. But again, we don't know. Is it helpful to inform the parent or not? That's just a big question. So she comes back. I don't know how much you're able to hear, unfortunately.
My drinking became out of control. I had lost my job, and my mental health had spiraled down. After a couple of months, finally got the strength to try to reach out to a psych provider for treatment, and she did help me. It was just hard to have that relationship and be fully trusting. I was never fully honest with any of my providers. I told them just enough to receive what help I felt like I needed, but it was never enough. And then my psychiatrist passed away from medical complications, which spiraled worse, because then I was devastated that I had to find somebody to really build that trust with again. So after going through a few different providers and not having that relationship, I kind of gave up again. I made the decision that I wanted to get clean because I was tired of feeling the way I was. I was tired of wasting so much money on alcohol. I had children. It wasn't fair to anybody. So about 6 months into my recovery, I felt myself craving and really on the verge of slipping up. So I went to my primary care provider and had asked about Vivitrol. And she looked at me and said, "Who raises your kids?" And I said, "Me." And I just felt so bad because I am a full-time mom. I was doing everything. Although I was abusing substances, I was still a good mom. And I just felt that she was judging me because I did have a substance use history. After feeling so judged for actually reaching out for help, I decided that I guess I'm just on my own and have to do this myself, which nobody should ever have to feel, especially when they become vulnerable with a provider and are asking for help. So I struggled and kept going through psych providers and everyone, because I just never felt that connection. And I started wanting to feel like I wanted to give up, but I knew I had come so long that giving up should not be an option. The cravings were terrible, the using dreams, the nightmares, but I felt that I couldn't open up about that. I just had to internalize that. So finally, I kept pushing through and pushing through. And in April of 2023, I was on my way to work and there was a mass shooting at Old National Bank downtown, and I was maybe 50 feet away from the incident and witnessed everything. At that point, my cravings got worse, my mental health deteriorated more. So I finally reached out and was was like, I have to give someone an opportunity to help me. There has to be someone in this world that does want to help me. So I reached out to get psychological testing and medication management changes. And I finally found someone who I felt comfortable opening up to.
I'll pause here. So I guess the big question in that is, so she talks about how first she did open up to a provider. Unfortunately, that provider died. Then she didn't go to anybody for a while. Then she went to another one who was very worried about liability. Hey, who's taking care of your kids? I get it. I guess that's binding on us. But again, that being the first thing you bring up to your patient, I think probably not a great idea. And also it tells you, what are you thinking about more, your liability, your anxiety as a provider, more than patient-centered care. So again, that made her discouraged again. Then she waited forever until her symptoms got much worse, and then did finally go to someone who didn't make her feel judged. And that's what really helped her get sober. So that's the value of a provider who does not stigmatize the patient with this. John came back again. He spoke about, I guess in the interest of time, I'm just going to summarize what he says over here. So he is now just the, he's the head of the nursing at the 7 counties. And he also was, prior to this, he was working somewhere else, I think in I don't know exactly, but it's substance use, I think, residential, where patient had some medical reasons. So they asked the patient to walk to the medical hospital across the street. Patient came back after several hours and said, they're not treating me. So John said, what do you mean? So John took his badge off, wasn't in scrubs anymore. He said, I'm just going to go see what happens. He walked with the patient to that hospital. They again waited in the ER room for several hours, and he heard the nurses across the room say, oh, he's just an addict. We don't need to get there yet. So he went and then talked about this to the higher authority. What is this? So that was his experience for his patients. And he also mentions how, this was a good point that he raised, that he looked at the curriculum of the nursing and so the section of mental health that is dedicated to addiction treatment is 2 paragraphs. So he talks about how we are not doing enough to train people in this. And then he talks about also how science has advanced, but our stigma and culture is still quite behind. The science is talking about the disease model, but we as healthcare providers are not following up with that. Have we made any progress so far? This is a picture we took. Dr. Stewart, along with another provider, did actually Narcan training for medical students. And now we know Narcan is available over the counter, which is great. Now we know X waiver has been removed. So like anyone with a DEA can prescribe Suboxone. Again, that's the rule, but it's going to take a while for everyone to catch up. The language change in DSM. This was a testimonial by another provider who is a radiology resident. I don't know if you can hear him. This is real quick, like a minute and a half.
Hi, my name is Mohammed. I'm a radiology resident. I did general surgery as my intern here, and I plan to pursue intervention for the rest of my career. I don't think I formally received any training in how to deal with patients with substance abuse disorder in my medical school or even my past couple of years of residency. But I think I carry a certain bias. I went to an elite school and over there in order to get accepted, and it was considered more fashionable if you were into drugs. And I saw a lot of feds get into it. Some of them got addicted to them, and I even unfortunately know a couple of friends who lost their lives to it. So I carried that bias, and I absolutely agree with the fact that the biases do affect how you treat your patients, and it carries on to your care and how you treat your patients. I personally think I definitely recall one patient. He was like a 35 or 40-year-old male who was dealing with substance abuse. He was not able to keep his job, and this time he was admitted in the hospital under vascular surgery for vein thrombosis because of using hypodermic needles. And I would spend extra minutes during the morning rounds in his room just because I felt for him and I knew that he was struggling with it. And even though my team always wanted to move ahead, and after like maybe a week of rounding on him, they decided to just leave me in that room by myself because they knew how much I loved talking to him and giving him support.
Okay, I'm going to pause here. So he talks about how he was working on a surgery intern year, and he felt a positive bias towards the patient. He would spend more time. The rest of the team would just walk off and say, we'll leave you here talking to him. And then he talks about how maybe having personal experiences and better training gives you a better standing to work with his patient. To me, that question is like, oh, does every healthcare provider need to lose a loved one to addiction before we actually develop empathy for this population? Because that's where he was operating on. He didn't get any training, but he felt positively because he had some personal history with it. I think we need to be doing more than that. Dr. Stewart talks about a great point about
stigma is a huge barrier.
No, it's short. It's just
getting the services and treatment that could otherwise benefit them. The only way that really I think stigma can lessen in any way is through having providers and patients and families in our community experience recovery. Recovery from addiction and success in treatment. You're not going to get over the stigma by just dealing with the failures over and over again. And what we set up our system to do is for our learners and our students to experience the failures over and over.
Can I pause that, Dr. Short? Is that okay? So the big point, I thought it was really helpful for him to share that we need to experience more and more recovery. And I think for me, in my residency program, I didn't get to see a lot of people with recovery. That was a great point. So, I mean, hopefully we shared some recovery stories. And Tisha, in case you were thinking what happened to Tisha.
I in the field that I'm in now, and that's when I started going back to school, just because there's so many areas that are great. So that's one of the reasons why I'm in social work now, so that I can at least, just provide some light.
So she's gone to school to be a social worker. She wants to provide some light. I thought that was powerful. Thank you. So what will it take? Some questions. Do we need more trauma-informed care? Do we need more training in implicit bias? Do we need to work more from harm reduction model? Do residents need to rotate on SUD service? Do we need to start doing Suboxone induction in EPS? Do we need to start educating the medical teams to start MOUD on the service without having to always consult the SUD service? Do drugs need to be legalized? But what will it take? What are your thoughts? Thank you for listening. Thank you. Sure.
So thank you for the comments.
Thank you.
You made several movies and they talk about how there's a disease, the brain is changed by substance use. It's not a substance of choice, but they don't have a choice. I'm curious throughout your fellowship if you modified any of your beliefs on free will. Do patients have free will, or their brains have really been changed by substance? I'm wondering what choice does agency have? Something where our science continues to tell us that our brains can control a lot of these behaviors, substances really make actual physical changes. That stuff's scary.
Yeah, I did sort of when I gave a disclaimer with it as well, that has been sort of people debate how much of willpower do they really have at the end of the day, how much personal responsibility do we just take all accountability away from them? I don't think there is a straight answer that I would have to that, but there is certainly some role of the behavior in therapy, and that gives us evidence that maybe working on the behavior piece is teachable. That's where we can do some work, but there is also evidence that there are brain changes, right, at the same time. But can we take that as a pass and be like, okay? So again, no direct answer, would vary case by case, obviously. And I think, but just, I don't think we can deny the brain changes piece. So this is that. Thank you. Yes, please.
First of all, it's a wonderful presentation. I'm working in EPS right now. It resonated so much with me, and I was like, this is so us. This is definitely what I have been guilty of, and everyone else. So, my question was, we see so many patients in EPS, and they're still in the pre-contemplative stage of their substance use. They lack like insight and judgment, and we see the damage is to them, but they don't see it yet. So what should your approach in dealing with those patients? Just, kind of gentle advice, or kind of like other than providing them resources and
Great question, and thank you for your honesty also for agreeing that that's what you felt as well. I think there's only so much we can do on an individual level as a resident. Yes, you can be empathic, you can listen, you can spend more time doing motivational interviewing. You can do that. You can see where they are. If they are pre-contemplative, let them know they can come back and you can help them, just keeping the door open. But then there's only so much you can do individually. There has to be some systemic change. Like we need to have more resources available. So that's something, maybe should we have beds for induction of Suboxone? Should we have beds for alcohol? And, we should probably not discharge them if they're motivated and be responsible for transferring them to substance use treatment programs, because we typically just give them resources, say, hey, walk over to JDAC and do. So yeah, just food for thought. There's only so much we can do individually, but it starts with one person. Yes, Dr. Stewart.
Great talk,
Thank you.
great, not just because you included me. And all the adversity in here, you handled that really well. It's clearly that you are a media person. I think that you do talk a lot. And if you haven't checked out Dr. Waseem online, you should check it out. She's got all kinds of videos. She's clearly someone who communicates a lot. The way you communicated was really good. And the way you won the confidence of the people to talk frankly with you, they were willing to give you the testimony, speaks a lot to the effort you went into to get them to be honest and open up for a presentation. They're not gonna have any privacy with this. I think you ought to give this talk some other place. I don't think it should be the last time you give this talk.
Thank
I really hope you do give it other times. Figure it out. Thank you.
Thank you. Thank you. Yes, Dr.
The virtual viewers aren't hearing the comments in the room. so
Okay.
I'm just gonna
I can
repeat it
repeat them.
summarize.
Sure. There was a question raised by a resident about EPS. What can residents do? And then there was a question about how much is the willpower and how much role of biology. Any other questions from the virtual viewers? I guess that's okay. Well, thank you so much, everyone who joined like in person. Thank you.